Thank you. We are delighted to be here to talk about lessons learned implementing and evaluating a cross-sector housing intervention to prevent eviction. I'm going to talk us through our background, which includes design of the program, a first evaluation that's already out in press, and then our redesign. Bridget's going to tell us how this program actually works, what it looks like. Bridget's our housing supervisor. And then I'll talk about preliminary findings from our second evaluation for the refined program and some conclusions. We are from Brigham and Women's Hospital. We're a large academic medical center in Boston with an 800-bed hospital and 14 primary care clinics. We serve about 200,000 primary care patients, and this intervention is embedded in primary care. In 2018, like many of you, Medicaid started requiring screening for social determinants of health, and we began screening. Every year, we've screened an increasing number of patients, so 12,000 in 2022. And what we've learned is that half of the patients we screen positive for one need or another, and 30% of our patients screen positive for housing instability. In 2018, we also decided to create a single order to respond to these needs. So in EPIC, we created an order where when a need is identified, anyone on the care team can write this order, PCP, social worker, front desk staff, anyone. They check off how urgent it is, which clinic they're at, and what the need is. And that then goes to a single social care team with 3 roles. We have community resource specialists who respond to these referrals through the work queue. They're our first responders. They provide telephonic support only and provide resource information, and they serve 60 to 80 patients per month. They can escalate those patients to a community health worker or our specialized community health workers, the housing advocates, and those are individuals who provide relational support in the context of a trusting relationship. They carry a panel of 30 patients for 6 months for our usual community health workers and 6 to 12 for housing. And they prioritize homelessness, eviction prevention, and other housing needs. From the beginning, we've supported this team with biweekly multidisciplinary case review with a legal partner at the table, which has been really helpful. Our first mixed methods evaluation found that the housing program participation was associated with reductions in outpatient care, and those were driven by behavioral health care, social workers, psychiatry visits, and urgent care. And our second finding was that patients reported physical and mental health benefits that they ascribed not only to obtaining new housing, but patients who didn't change their housing reported better health because of the housing advocates' compassionate and respectful support for them. And I encourage you to look at the article because it's got these breathtaking quotes from the patients themselves in it. The third thing we learned, though, was that screening identifies a huge volume of needs. So when COVID came, initially we had about 20 housing referrals per month to our team, and that skyrocketed to 100, then 250, then 350. We currently get about 300 housing referrals per month to our team. And that those case types were variable intensity. So on the right, you see the distribution of case types, and the big green bar, which is a third of the referrals, were for patients who were stably housed. So we determined that in order to respond to this volume with the expertise of our housing advocates, we needed to redesign the program itself. And we introduced a triage system. We added a legal partner who represents our patients in housing court if they're in the process of being evicted. We hired more housing advocates. And we created and did some fundraising for an emergency fund for one-time costs that were barriers to obtaining stable housing. So if a patient had a place that they could go, it was sustainable for them and affordable for them, but they didn't have first, last, and security, we could pay the security. Something like that, moving costs, things of that sort. And we did a second evaluation. If you want the details on the redesign or any of the tools I'm about to describe, they're in this other publication, okay? So the triage was really the key, and we first began by defining and creating operational definitions and illustrative cases for the case types in our sample. So we defined homelessness and at risk of eviction and unsafe and unhealthy housing, and we also defined what it meant to be stably housed but desirous of change. And that might have been somebody who was doubling up, but it wasn't a subsidized apartment. The person they were doubling up with wasn't at risk of losing their housing because they had an extra person there. And they weren't saying you got to be out in a month. And we as a team made the very hard decision that we were not going to address those cases. We were going to give them information and partner them with a community partner, but our housing advocates wouldn't serve them. We created a script for our community resource specialists to identify the case types and a smart phrase for them to document in the medical record. And those top 3 red case types, they were expected to discuss with the housing supervisor. So our housing supervisor, who is Bridget, would receive all of those referrals, and she would determine in conversation with them what happens next. And she's going to tell us, what does this really look like? Go ahead, Bridget. And tell me when you want the case.
All right. Thank you, everyone. As what Dr. MaryCatherine said, that the CRSs would screen the patient, and then I would look at them in these buckets here. I call them buckets, right? And with the CRS, we have had patients that are at risk of an eviction. I talk to them about, like, where they're at in the legal, in court. What can I do to prevent this? So as, I don't know if you all have it, what we have it in Boston is that we can go into the court and see what's happening with the case. And then that indicates for me what's my next move. So that's what we do here. The CRS sends it to me. I make a determinants. I either allow them to keep it, and I'll provide them resources. Sometimes I do conference calls with the patient with the CRS just to help educate the CRS, because they're going to come across some of these cases eventually again. So part of me is that I'm an educator. I love to educate people. If I can educate you and make you comfortable and confident, we'll be able to assess patients in a more efficient manner. So I'll do that piece, or otherwise I'll send it to my housing advocate. Sometimes I keep them myself. Yeah. I'm ready. Okay.
I got you.
Oh, okay. Sorry.
There you go.
Okay. So I'm going to present you a patient here. He's a 65-year-old man with COPD on oxygen. He was referred to me by his PCP, and you see it says a 3-day urgent. That's a patient that had those red areas. That's a 3-day urgent. And when that happens, I'm immediately moving quickly, because I don't know what's coming next for this patient. And my goal is to prevent eviction as quick as I can. So he lived in his apartment for 20 years. The homeowner, the original homeowner, she was elderly, her husband passed, so she wanted to sell. So she sold it to someone who said they will keep him there. And then 2 weeks later, they filed a notice to quit, right? So the CRS did their triage process. They called me. It was like about 4:30, 5 o'clock. I always get urgencies like 15 minutes before I get off the clock. I tell Dr. MaryCatherine, my day doesn't start till about 3:20, you know? So she called me. I looked him up in housing court. I was like, oh my goodness, this man has filed a summons and complaint, which means it's the eviction beginning, okay? So I called him, you know, and he was kind of like not believing that this landlord was doing this to him, because he said he's a nice guy. And I'm like, sir, if this what you call nice, I would hate to see when he's not nice, right? So I had to really help him to work with me. And I said, sir, I'm just saying to you, I'm very concerned. So, you know, part of this work is developing a relationship. Because if you don't have a relationship with someone, they are not going to trust you to move them forward. And to me, relationship building is my key to what I do and what I've been doing. Okay, so we contact legal. I said, sir, I need you to give me verbal permission before I document it in the health record. He gave me verbal permission to contact legal. And then I did the release later. I did home visits every week to do housing applications with him. Like every week I went to his home and did housing applications. The landlord was doing renovation, which created more issues for his health. And then we did a lot. I mean, like I met him in September 2022. I got him housed August 2023. I got him housed because I was I was on it for him. And he worked with me. As you all know, if the patient worked with us, things will move quickly, right? He got stamps, he got envelopes. He said, Bridget, you tell me how to do it, when to do it, and it's done. And he did. Him and I worked together. But I got him housed. A lot of work, but it was great work, right? I got a reasonable accommodation letter for him, and this is him in his new apartment. This is him. He said to me, he said, Bridget, this is my dream home. He's in a part of Boston that is very expensive, and this is a brand new property I got him in, right? And he said, Bridget, I couldn't have dreamt of anything better than this. Whole Food is down the street, his bank is down the street, restaurants is down the street that he loved to eat at, and he's in a motorized wheelchair, and he can get out now. Wow. Before he was stuck in his home. He said, Bridget, I can get out. So he just loves it. The lawyer was able to get him a settlement, that because the conditions of the unit, I'm telling you, this is like the best situation that could have happened to him. I really appreciate him trusting me. His female partner, she had a hard time because she did everything for him. And to have another female come in, it was a threat to her, right? And I said to her, I said, listen, I'm just here to help. And I said to him, if this is a problem for you, I need to tell your doctor. I gotta go. And he was like, no, I need you to stay. So this is the work I've done. And it's in the article.
Thanks, Bridget.
You're welcome.
So we've been doing mixed methods evaluation of this second evaluation, and we have preliminary findings on whether the triage worked and what the experience and perspectives of providers are. We're still working on the quasi-experimental outcomes for utilization and quality, and then we've been doing interviews about the role of the legal partner with the patients from the patient's perspective. So that's forthcoming. But the first question was, does this triage process work, right? And what we see here is the original study is the blue bars, and the purple bars show that 60% of the patients being served by our housing program currently are in the process of eviction, and that's what we wanted. We also saw that before this triage, one of our housing advocates spent 30% of his effort trying to reach patients he never got to reach, and that's now 8%. So the triage, putting this housing program within a larger social care chassis that involves telephonic support has been crucial to being able to do the intensity of work that Bridget just described for the patients who need it. Half of the patients who were facing eviction during this time period avoided eviction, and another 4% got no-fault evictions. So it's not always possible to forestall or eliminate the eviction risk, but what the lawyer does is he drags it out. So that patient never wound up on the street. He wound up in his brand new apartment from one place to another. Almost a quarter of patients get legal partner representation and support, and 30% obtain permanent, stable housing. What we learned from the providers is that these needs are pervasive. Providers like me have no idea what to do. I've learned so much from Bridget, and that it lets them focus on clinical care. So can I ask you to read this, because it gets me all choked up? But this is what one of our providers said in an interview, and I just want to take a minute to hear the words of providers.
With the greatest thing that has happened in my practice, and I've only ever practiced primary care here. Like, I trained here and stayed here. The social care team has been the greatest advance. Being able to say, I'm not holding this alone, and I'm not expected to be an expert in this incredibly complicated thing, which is housing or food or transportation or like all of the other things. But this one is like the beast, right? Housing is, and it changes all the time. I can't be an expert in hypertension and also in housing. To be able to partner with a team where I say to the patient, we can help you with this, and it's not on me, my responsibility. it's my responsibility to make an appropriate referral for you. This actually feels like I can learn and I can say, listen, I'm going to make this referral, and I know a little bit about what they're going to need from you, and I know a little bit about how they might be able to help you, but they're really the expert. That's been so liberating for me as a doctor, and just so comforting, right? To say, this is so important, and we're going to assist you with it, but not just me is going to assist you, somebody who is actually expert in this. That's been like the kind of moral distress that we talk about all the time. This has been an enormous, enormous source of relief that is incredible.
Thanks. One more thing. Our sustainability, we have formed a public-private partnership with the City of Boston. We currently continue this program as is, but our staff is paid by the City of Boston. They provide ongoing training for our team. They help us advocate with other city agencies and build additional collaborations for us. The challenges have been that now our team double documents in their system and in the EHR. It's restricted to the City of Boston, so we have patients we can't serve, and the referrals are not all our patients. But they've been much more flexible than I anticipated, and they incorporated a question in their intake, where do you get primary care? So they try to send us patients of ours when they can. And the implications for this is, I think, tiered approaches really help. A full team, the housing support embedded in clinical care improves the care of the whole person, and maybe reduces moral distress among providers, and that these cross-sector partnerships are facilitating sustainability over the long term. Thank you. That's our housing team on the upper right.